All right, we're going to talk about medications for intracranial regulation. I'm going to start with narcotics. So pain, of course, it's subjective. Every person's going to have their own experience of pain. Only that person can tell you what they're feeling. So you have to take them at their word. Certainly you want to look at the clinical picture. If they're telling you they're a 10, but they're sitting there talking on the phone and relaxed, we may want to just kind of educate them on what the 0 to 10 scale is, and see if maybe we can reorient them to that scale and maybe get a little more accurate measurement from what's meeting the clinical picture. But if they continue to say 10, then by all means, please, I definitely believe them and utilize your protocols and your orders to help however you can. Pain can obviously be acute or chronic, mild, moderate, severe. There's different ways to describe that pain. We talked about that with in fundamentals, probably MedSurg 1 as well. So what's our non-pharmacological treatment for pain? What can we do to help pain besides just throw meds at it? So think back to, again, fundamentals, MedSurg 1. What we talked about to help people with pain. So distraction techniques, massages. Some people use like aromatherapy. There's guided imagery. There's quite a few different ways that we can do that. So anytime you're going to give an analgesic, which in the hospital a lot of times is a narcotic. Not always. Sometimes you're given ibuprofen or acetaminophen, but a lot of times it is narcotic based. But anytime you're going to give an analgesic, make sure that you also document what other non-pharmacological treatments you've done. It's always an important thing to do. Opioid agonists. These are the narcotics, right? These are the narcotics that we give. Remember back to lecture 1 when we talked about core concepts and our schedules and the difference between a schedule 1 and a schedule 2. And really the only difference is one of them has medical uses, right? Or acknowledged medical uses, whereas schedule 1s don't have any. So schedule 2 has all the same potential abuse and addiction properties, but they have some medical use is noted, whereas schedule 1 has, in some cases, maybe not quite as addictive or abusive. However, there's no medical use, so they're schedule 1. Opioid agonists, these are the schedule 2s that are highly addictive, highly abused, and yet we're giving them all the time. So we want to make sure we get a good, accurate pain assessment before we do these. Obviously, make sure we're using our non-pharmacological pain interventions as well to help reduce the dependence upon the narcotic pain medicines. But let's face it, we're dealing with people that have had major surgeries or major accidents, and they're in a lot of pain, and these medicines are great for that. So definitely make sure you do good assessments, good documentation, but also don't be afraid to give the meds. Use your good clinical judgment. If they look like they're getting lethargic or they're getting too much, certainly don't keep just pouring, the medicines on there. But at the same time, don't hold medicines, when someone's truly in pain, and don't act as though you're the only one that knows whether they're in pain. Again, trust the patient and look at the clinical picture when you're doing these. So just always take safety into consideration and just be and always be thoughtful about opioids when you're giving them. The classic opioid agonists that you're going to give, morphine and hydromorphin. Fentanyl is one as well. Oxycodone and hydrocodone, those are PO meds. Those are the more common ones. Codeine is one as well. You don't see that as often though. at least not in an adult population. And there are others, but the more common ones that you're going to see injectable wise is morphine and hydromorphone. Oral is oxycodone and hydrocodone. Those are the most common ones you're going to see. The action of these meds, these actually activate. A lot of people think that they block or that they turn off receptors, but they don't actually. They activate the opioid receptors or the mu receptors. And by doing so, that produces the analgesia, so the pain relief, but it also produces sedation. And then in some people, it heightens a sense of well-being and euphoria. And so some people, they will chase that. That's one part of that leads to addiction. Our indications, pain. That's primary anyways, usually moderate to severe pain. There's a few other reasons we use these. You'll see these used sometimes as an adjunct to anesthesia. So, if you work in surgery or anywhere that does procedures, a lot of outpatient procedures definitely use this as an adjunct. But you'll get this along with whatever they're using. So if they're doing conscious sedation, they may use, a pretty good dose of opioid medication along with the benzo in order to produce that sedation or whatever they're using, propofol, whatever they're using. So an adjunct to anesthesia. And then sometimes we use it for cough suppression, which we talked about with respiratory medications. And sometimes it's actually used to help people with diarrhea. Some people have problems with chronic diarrhea for various reasons, and they may take, it's called opium tincture is usually the one that they use for that. It's an opioid. Again, it's usually just like the cough, it's a smaller dose, so it's less likely to cause the addiction and abuse, but the potential's still there. But that's one of those adverse effects of opioids is constipation. So in people with diarrhea, sometimes they'll use these to help them with that. Adverse effects. We just talked about constipation, and certainly we need to keep that in mind. Urinary retention, we need to keep that in mind. But the most pressing, the most concerning adverse effect, the one that you absolutely have to check every time before you give it, is respiratory rate. It can depress respirations and also cause sedation. So if you're having to wake someone up, every time you wake them up, they're, oh, I'm a 10, and then they fall right back to sleep. Those are the people we got to be really careful with. We don't want to just go throwing narcotics at them because they may be already oversedated. They may already be, they may already have too much narcotics in them. Those are the ones we got to be really careful with. So make sure you're doing very good assessments when you're giving narcotics. Respiratory rate is solid, their oxygenation is good, they look good, and they're not heavily sedated already. Other potential adverse effects, nausea and vomiting. That is true for both PO and IV or IM, but when you're given this stuff IV especially, if it's their first dose, give them a little bit, or see if the doc will give you some Zofran to go with it, or ondansetron is the correct name for that. I've given it so much where where the doc didn't write for ondansetron. I ended up with seeing the patient with nausea and sometimes vomiting. Another thing you can do is make sure you push it slow, and if your policy will allow you to dilute it. That's normally what I do, especially with like Dilaudid or big doses of morphine. But if you push it too quick, they're going to definitely get nauseous. It's very rare that you push it unless the person's like used to pain medicines, at which point pushing it quick for them a lot of times doesn't seem to have that effect. But I still don't. I push it slow on everybody. I don't care who it is or what they've had done. I'm gonna take a minute or two to push that medicine depending on the dosage, because I don't want to cause these adverse effects. So be careful when you're pushing opioids. Make sure you push it slow, and watch for that nausea, vomiting. And a lot of times I will, especially if it's their first time having it, or if it's their first time having it, this hospitalization. So yeah, they've had it in the past, for past procedures or whatnot, but it's not like something they take every day. I don't know. That's generally been my rule of thumb in the ER. Say, hey doc, can I get, and usually the doc actually writes it, but every once in a while they don't. And it's like, hey, maybe we could do 4 of ondansetron with this. And I've yet to have a doc say no. They're like, oh yeah, no, that makes sense. Because of that potential for nausea, vomiting. So you'd hate to take away all their pain, which is good. You do want to do that, but then just throw them right into nausea and vomiting, and they're sitting there retching, and then they're miserable for a whole other reason. So nausea and vomiting is definitely a very common adverse effect. Orthostatic hypotension is another common adverse effect. So anytime you're going to give these meds, these are also they're going to make them dizzy. They can make them confused for sure, especially depending on the dosage and the age of the patient and medical condition, really. But, anytime you're going to give these, make sure you put them on fall precautions, put that bed alarm on, give them the call light, make sure that they understand they need to call you and not get up without you being there. Use gait belts, because there's definite potential for orthostatic hypotension, dizziness, drowsiness, the whole bit, and confusion. So we want to make sure we're protecting them with that. Addiction is another potential adverse effect. We all should know that by now with opioids. It's everywhere. You can't open a newspaper anymore. Of course, you can't really open a newspaper anymore anyways, but you know what I mean. Can't turn on the news without hearing about opioid addiction and the problems that we're having with it. So we'll keep that in mind. I'll tell you this, though, be careful. Don't just judge people, even if they have a history of addiction. If they need the pain medicine, they need the pain medicine. I've unfortunately run into situations where the doc just refuses to give pain medicine to an abuser, but the abuser is obviously in a lot of pain. Or they'll decide they'll go ahead and give it to him, but they'll only give him like 1 milligram or 2 of morphine. But let's be honest, if you're loading up on heroin, then what's 1 milligram or 2 of morphine's nothing. I mean, whereas someone, that's not used to it, if you gave me 1 milligram of morphine, you're gonna have to pick me up off the floor. But people that are used to it, man, they're probably not gonna be much. So let's make sure we're still taking care of those guys. And that can be a tricky situation. You certainly don't want to feed into that. But the worst would be to not relieve their pain. Unrelieved pain, as we learned in fundamentals, and I'm sure you discussed in MedSurg 1, leads to a lot of complications. If they're post-surgical, the healing time goes way down. We're increasing the stress on the body, so we're increasing the risk of infection, hypertension, all kinds of nasty, ugly things. So we want to relieve that pain, but we got to be smart about it. We've got to use our good nursing judgment and make sure that we're being safe for the patient at all times. Contraindications. Your major contraindication, of course, if we look at our adverse effect, and our major adverse effect is respiratory depression. You would not want to give this to somebody who's got respiratory impairment. If they're in a coma, I'm not saying that you'll never give that. But if they're completely out, completely sedated, we would certainly move with extreme caution. Make sure that you're discussing this with the doc, and that you're everyone's on board with what's going on with the patient. Labor and delivery. It's not fully contraindicated in labor and delivery. I've seen it in labor and delivery, and that's just in my very limited experience in L&D. I try to stay away from labor and delivery as much as possible, but I've certainly seen it, and you may have experienced that in your own life. They do sometimes use opioids in those situations. Most commonly, however, though, it's an agonist, antagonist, which we'll talk about that next. Full-on opioids, though, has certainly been used, They just would prefer a lot of times the agonist antagonist for reasons that we'll get into with the next medicine. Be careful in people with a history of substance abuse, like we talked about, people with decreased levels of consciousness. Careful with the elderly. They're more apt to be confused and to have those adverse effects. They're more apt to get that respiratory depression quicker. So just be really careful with them. And children, be careful with children as well. Interactions, anything else that's going to depress the CNS, anything that's going to cause that dizziness, drowsiness, would certainly interact, because we're going to just potentiate all of that and further increase the risk for respiratory depression and decreased level of consciousness. It can also interact with antihypertensives. These medicines, as we talked about, constipation, urinary retention, these are some anticholinergic effects that these medicines have. So any other med that causes those anticholinergic effects, you can potentially potentiate that more, right? So more at risk for constipation, urinary retention. And then MAOIs, because as we will soon find out, everything interacts with MAOIs. Patient teaching. So what's super important about the patient teaching? Again, take only as directed. Do not take more than you need or than has been prescribed for you. Do not share the medicine. Another really important thing to teach is, because a lot of people are aware, obviously, of the addictive properties of these medicines. So it's quite common for patients to just think, I can't take these because I don't want to become addicted, so I'll only take them when pain gets unbearable. The problem with that now is you're chasing the pain, and unrelieved pain, just like we talked about, can lead to all kinds of problems. So they really need to be taught to take these before the pain reaches its peak. I've run into this in my own life with a loved one who had surgery. I was there at the bedside, and they just went on and on about how great they felt. And they had a close friend who became addicted, and so they were worried, and so they were going to be very careful with the pain meds, which is good. But the problem is, post-surgical, you got that nerve block. And at least she did. A lot of people do. And so you feel fine. You're like, heck, I don't have any pain, which is exactly what was going on here. And the nurse was like, well, you should probably go ahead and start taking these Percocets now. And my loved one was like, no, because she's scared to death. Doesn't want to become addicted, and I can fully appreciate that. We encouraged her, and she's like, well, I'm going to just give it a little bit more time. So, okay, fine. The problem was, she was already starting to feel the pain a little bit. And once you start feeling the pain after that nerve block, you really got about maybe 30 to 60 minutes, maybe, before it's just full on, oh my God, my leg's falling off, or my arm, or whatever the pain is. And that's exactly what happened. And then they were chasing the pain the rest of the night. So her fear of getting too much pain medicine became a reality, because of the fact that all she wanted at that point was to get the pain relieved. And a lot of times you'll overshoot it trying to get that pain relieved, and now you're dealing with the other end of it. So really encourage people to take the pain medicine before it reaches its peak. And that is a fine line to walk, and you'll get better at it. Just stick with safety. Always stick with safety first. Anytime you're given these meds, and you should be fine. You'll get better at understanding how to walk that line. I'm very conservative with my meds, so especially at first when I was given these, and now I understand the importance of getting them before the peak, and how to kind of manage those. I've done better, but heck, even the most experienced nurse, everyone's different, so you're gonna have times where maybe you overshoot it a little bit. Just be really careful. Make sure you're doing good assessments. And always following up. Anytime you give a pain med, make sure you follow up within an hour, usually for PO, within 30 minutes for IV, to see how it's relieving their pain, and also to check to make sure they're not getting too sedated. So again, don't share the pain medicines. Don't take more than ordered, but take these before it reaches the peak. Also, they want to avoid alcohol. We'll want to tell them, obviously, don't do anything that needs your full alertness. Don't drive or operate any heavy machinery while you're on these medications. And then we'll also teach them about non-pharmacological measures to relieve pain, whether that's ice, a lot of times, depending on if it's a surgery, like knee surgeries, a lot of times we'll use ice and different types of surgeries, or just, the distraction techniques, whatever it is that you guys are, or that is working for this patient. PCAs, you may have seen these in clinical last semester. We talked about them, I know, in fundamentals a little bit. The patient controls the analgesia, not completely. It's just a button that they push, and when they push it, they can get a set amount of medicine. So let's say it's a milligram of morphine, it's possible, 0.5 milligram to 1 milligram morphine every 20 minutes for a lockout of 3 milligrams an hour. That's pretty common, actually. What that means is when they push the button, they'll get 1 milligram of morphine or whatever it was programmed for. And then they can push the button as many times as they want over the next 20 minutes. They're not getting any more until that 20-minute interval is up. Once that 20-minute interval is up, they can get another milligram. Now, if they push the button and fall asleep, and they get 2 hours of sleep, and then they wake up and I'm still in pain, they didn't keep getting the medicine because they weren't pushing the button. They only get it when they push the button, but only within those intervals. So again, you can push the button 1 million times during a 20-minute interval. You're only going to get it during those 20-minute intervals. You can push a button once, and then an hour later push it again. It's been over 20 minutes, so you can push it and you'll get the medicine again. But it's not like you're giving it to you every 20 minutes. There are ways to set up a PCA for continuous administration, and that does happen, especially when you get to PCU, ICU, sometimes in ER. You'll see that. And then it will also have the breakthrough push button. So there's different ways to set these up. But whenever the patient's given it, it's only at set intervals. They can only, every time they push it, it's not like it's a constant, okay, we're going to set up for 1 milligram, let them have as much as they want. Morphine and hydromorphin are the most commonly used medicines that you'll see with a PCA. What you need to make sure you do with a PCA, there's a couple big things you have to do whenever you're setting up a PCA. One is ECO2 monitoring. Nowadays, I've yet to work anywhere that doesn't have ECO2 monitoring on their PCAs. That's just a little extra add-on that you put on to the pump, and you connect a specialized tubing to it. Now, that tubing can be hooked up to oxygen, but it does not have to be. You don't have to have oxygen on, but it has that ability to do that. But it does have to be in properly, which is there's a little plastic mouthpiece that goes over the mouth, and it measures respirations and ECO2, and then it will alert anytime that respirations or CO2 get within a certain range. I use these on all my patients, and I would never let a patient have a PCA without one. If they want to take one off to have dinner, that's fine. I'm going to go ahead and turn the PCA off too. You can eat your dinner, and then we'll put that monitor right back on. I would never just leave them with the PCA without that on and turn off the ECO2 monitor. You're just setting yourself up for a problem, because things happen on the nursing unit. Maybe you get pulled away for an hour or more just working on a code and working on something. One guy's coding, another person's got discharge paper, and they're screaming at you they want out of there, and it can be over an hour before you get in there to check on them. If you left them on a PCA without an ECO2 monitor, you're just setting the patient up for a big problem. So now I would never, ever turn it off I would never let them have the PCA without the ECO2 monitor, even for a short period of time. It's definitely worked. I've absolutely had success stories with the ECO2 where we were able to save somebody who was circling because the ECO2 monitor went off. you're checking on these guys as much as possible, but when you're on a busy unit and, if you've got 5 or 6 patients or more, it could be over an hour before you really get in there and check on them. So that's a big one. Make sure they have the ECO2 monitor on. They absolutely have to have that. And the other thing is make sure that there are signs posted and that everybody that comes in that room understands that the only person that can push that button is that patient. Mom can't push the button, dad can't push the button, girlfriend can't push the button, boyfriend, no, who cares? Whoever it is, grandma, I don't care. Grandma's been a nurse for 30 years, I couldn't care less. Grandma best not be touching that button. You cannot touch that button. You're the nurse, you can't touch the button. If you have to touch the button in order for them to get the pain medicine, then we've got them on the wrong thing. Because the whole point of a PCA is that the patient pushes the button. If they don't have that capability, maybe we need to look at some other form of pain relief for them. This may not be the best option for them. So again, you can't push it. Nobody can push the button but the patient. There's definitely horror stories out there. You can get online and look them up of parents who were doing what they thought was best for their son or daughter. They just got out of surgery or they've been in a major accident, whatever. Mom's at the bedside, worried to death, and so every time they grunt, they fall asleep and and they're like, oh my God, he's starting to get pain. I don't want him to get pain. Pushes the button, and then maybe the patient rolls over and grunts again. Oh, pushes the button. Oh, look, he's breathing kind of funny. I'm gonna push the button. And there's definitely been episodes of family members who have killed a loved one inadvertently using a PCA. So again, only the person who's been prescribed the PCA can push the button. That's it. Nobody else can hit it. Opioid agonists, antagonists. We talked about these a little bit with opioids, especially when we're talking about contraindications for labor and delivery. These are the ones that we will see commonly in labor and delivery, and there's good reasons for that. They stimulate some opioid receptors, but then they can block others. So you don't get that full opioid effect, which means adverse effects are less marked. It doesn't mean they're not deadly. They are still just as deadly as far as potential for respiratory depression. However, it's not as marked as it would be with a straight opioid. Our indications are pretty much the same as our opioids, especially with the moderate to severe pain, adjunct to anesthesia. But these we do use during labor and delivery. And another thing that we use these for that we don't use opioids for is treatment of opioid dependence. Well, I won't say that we don't use some opioids for that, but you will see the opioid agonist, antagonist used for that at times as well. So treatment of opioid dependence to help them to get over that. Because again, we're stimulating some opioid receptors, but we're not stimulating them all. So that can help. Adverse reactions, again, the same. Dizziness, sedation. The big one is the respiratory depression. But we can still have a little constipation, urinary retention. All of it's the same. Nausea, vomiting, all of that's the same. I just talked about adverse effects on that last page. I'll go over them real quick. I sometimes get ahead of myself. But again, the dizziness, sedation, respiratory depression is the big one. Nausea, vomiting, headache, all of that's really the same as far as these go. As far as the opioids and opioid agonists, antagonists, they both have the same adverse effects for the most part. Just the true opioids, they're a little more apt to give those to you, or a little more readily. How about that? Be careful in people with opioid dependence. Now, I say that we do use these sometimes to help people get off of those, but if they're used for that purpose, fine. If they're not, and the person is opioid dependent, we need to really be careful with that. Be contraindicated in respiratory depression. Be contraindicated in certain head injuries, so you want to keep that in mind as well. Sedation, depending on level of sedation, it could be contraindicated sometimes in that as well. Interactions, any other CNS depressant, just like we talked about, that includes opioid agonists. Patient teaching, really exactly the same as your opioids. So, don't operate heavy machinery or do any activities that requires your full attention. Take before pain reaches peak. Avoid alcohol. Don't take more than ordered. Don't share the medication. And we'll teach them about the non-pharmacological interventions. All right, so what happens if we get too much opioid on board? What are we going to do? Luckily, there is a medicine that can cause immediate withdrawal, which is a great thing because it saves lives. The problem is there's some the side effects aren't deadly usually, but you need to be aware because you need to protect yourself at this point. So naloxone, also known as Narcan, it's also in the news a lot now because people, first responders are using it. They also, a lot of police officers have it on board because they're a lot of times the first people on the scene. And then also family and loved ones can have this medicine in their in their house for if they lived with someone who's addicted. It can save lives, and it definitely has saved lives. There's debate out there as to whether we should be doing that. You will find me fully on the supportive side of if you're going to save someone's life, do it. I don't care how many times you've done it this week. Why would you sit there and watch someone just die if you can keep them from it? So the action is that it blocks. This is a blocker of the opioid receptors. So a true opioid goes in, attaches to the receptor, and activates it. And that's going to cause that euphoria, the pain relief, the whole bit. And naloxone goes in, it attaches to those same exact receptors, but it just sits there and does nothing. But by just sitting there, opioid also can't do anything either, right? So if the naloxone's in the way, they both can't be on the same receptor at the same time. Naloxone has a greater affinity. I almost said infinity. I did. Affinity. And which means it likes those receptors more, usually more than the opioid. Unfortunately, there's some synthetic opioids out there, some synthetic forms of fentanyl. Fentanyl is synthetic, but there's some more nastier forms out there that they're cheap. We're getting them from other countries, and they're putting them in, mixing them with heroin or just selling them straight as heroin that have almost the same affinity as Narcan or naloxone, which is extremely scary. So it's taking buku amounts of naloxone to keep these guys, from overdosing. And you're giving it more often. It's just so scary, so scary to see. But anyways, I digress. Naloxone has a greater affinity, which means it's going to knock that opioid out of that receptor, and it's going to attach to it, and it's going to stick there. The problem is its rate of degradation is much quicker than an opioid. So an opioid will just sit there and be just sitting there. And then once the naloxone degrades enough to where it no longer has that same affinity, then the opioid's going to attach right back to it. So anytime you give naloxone for an opioid overdose, be prepared to give a second dose. Stay with that patient and monitor them closely. When you first give it to them, you are taking them out of wherever they are, right? Whatever euphoric thing they're feeling or wherever they're at, in there, you're ripping them out of that, and you're giving them back all the pain that they were escaping from, whether it's pain from the surgery or an accident or just from life or whatever it is that they were taking to make them take that medicine or take those drugs. You're zapping them out right back into reality, and you're pulling them back into it immediately. They hate you. Two things are going to happen. They may puke. Be prepared. They also may start swinging, spitting, scratching. I've seen people pop up. I've seen people literally start swinging. And some people, I'm going to be a little bit more worried about than others, because there's some big people who will come in and they start swinging. It's scary. So just know that when you give this medicine IV, make sure that you yourself are prepared to keep yourself safe as well as the patient, because that does happen. It's not like it's everybody. It's not everyone I've ever given naloxone to. They hated me for that short period of time afterwards, but very few have ever really swung or anything, but it's a potential there. So just know that. Just make sure you keep yourself protected. You've got staff on board that's available there to help you. And I don't want to scare you into thinking that everybody you're going to give this to is going to come out fighting, because that's not true. They will come out screaming, and they're going to call you some very, very creative names. Boy, I should have kept a log of the amazing curse words that I've been called after giving someone naloxone. And they're going to be feisty, but watch them, because the likelihood of that naloxone starting to degrade before the opioid is completely out of their system is fairly high, depending on what they took. They may go right back down after so much time, depending on what they took. And you'll need to be prepared to give them another one. In fact, there's been times when I've had to put people on a drip, because they've taken such a high dose of a very potent opioid, and we've given them multiple doses of IV, and they just keep going down. So we got to put them on a drip to try to get them out of it. And that does occur. So that's our indication. It's opioid overdose. That's the indication. Adverse effects. Okay, so I talked about they're going to come out. It's going to cause immediate withdrawal. So they immediately are going to withdraw from that opioid. They're going to, when you pull them right back into reality and all the pain that they were experiencing before hits them immediately, they're not going to be very happy. It's also going to cause heart rate to go right up. So tachycardia. Respiratory rate is definitely going to improve. They're going to go from like whatever you were seeing, 4, 6, 8, whatever it was that was bad. They're going to go right through the roof. They're going to definitely start breathing a little heavier. Heart rate's definitely going to go up. And of course, the withdrawal symptoms, they're immediately going to be in withdrawal symptoms from opioid. The good news is for the most part, people don't die from opioid withdrawal. Not like they do with alcohol withdrawal or benzodiazepine withdrawal. Those can absolutely kill somebody. Opioid withdrawal, I'm not going to say it can't, it's just not as common. They're usually going to be safe as long as you're there with them and able to intervene if the need arises. One potential adverse effect that could be troubling to the patient is pulmonary edema. That's usually when you put them on a drip or you've given them a lot. You've just had to give them a lot. It's always a risk-benefit thing, though. I mean, you got to get them out of the opioid withdrawal. So if that's the case, if you put somebody on a drip, just make sure you're doing good respiratory assessments. You are, obviously, because you want to make sure they're not getting respiratory depression, but do more than that. Actually start listening to the lung sounds once you start people on Narcan. Contraindications, there's not really any contraindications. You're going to give this if you suspect opioid overdose, even if you just suspect it. You don't know it. You don't know. So somebody comes in, they're not breathing. It was unwitnessed. No one saw what happened. A lot of times, I mean, you're going to start your ACLS and the doc's going to say, hey, man, let's throw 4 Narcan in there. Let's just see if it'll help. Because it might. And if it was an opioid overdose, and if it wasn't, well, whatever. It's not going to really hurt anything. Cautions. There's not a whole lot of caution. Your book's going to tell you addiction or dependence, but at the end of the day, if you need naloxone, you need it. Period. That's just, I mean, you're gonna just give it to them, and you'll deal with the consequences later. So, yeah, they're gonna hate you, but after they realized that you've help them immensely. They will, and once they come out of that immediate withdrawal, once they get reoriented to what's going on, I've yet to have anyone continue hating me. They usually stop spitting at me after a little bit. Interactions, well, the obvious interaction is an opioid, but we want that, right? That's what we want. We want that interaction. That's the whole reason you're taking the medicine. Patient teaching. All right. So patient teaching is going to involve family. You're definitely involving the patient as well. You're going to talk about, treatment programs if this was an intentional overdose, or I don't want to say intentional as in they were trying to kill themselves, but like they intentionally injected themselves with medicines for reasons other than medical. Sometimes you'll use this because we just gave somebody too much pain medicine. I've definitely seen that where the doc wrote a prescription, you were watching them, everything seemed to be doing okay. It built up in them, especially in the elderly. It'll build up. Remember, everything slows down. So it takes it a little longer for it to start working. So the doc maybe gives them a little bit more because it's not working. But then once it starts working, boy, it works really good and it stays there for a long time. So we've certainly seen that where we've given it. And at that point, I don't really need to talk to them about dependence, right? They just got we misjudged how much would be okay for them because everybody's different. And now we know, and we're going to be very conservative with that. But anyone that intentionally injected themselves with the medicine or intentionally took the pills for reasons outside of medical, we're going to talk to them about dependence and addiction and get them, to interact with those resources. We're also, though, going to talk to the family and get them involved if they're going home with the opioid antagonist. Now, obviously, you can't just call the family member, for HIPAA reasons, but if the family member is involved and the patient's agreed that it would be a good idea to have this medicine on hand. Now, obviously, the patient can't take it because when they're overdosed, they can't take it. It's going to be the loved one that has to give it to them. There's different methods for doing that. The most common method right now is intranasal. They need to understand, though, store it at a place where it's readily available. If you find the person down, immediately give them that and call 911. Nowadays, with cell phones, you can do that all at the same time, thankfully. It's important to get that first dose on. But if you have to go looking for the medicine, like, oh, I thought I put it here, but maybe it's over here. Now, call 911, right? If you know where the medicine is immediately, they need to really give that dose first and call 911. Because it's all about getting those respirations back as soon as possible. But that nasal Narcan or naloxone, it's only good for so long. In fact, a lot of times it doesn't even bring them out of it. It just brings them out enough to start breathing right. But they're still lethargic. They're gonna go right back down. So it's not like they found Billy down on the floor and they're like, oh, and they spray a couple sprays and he starts to come back and like, okay, well, we're gonna go gambling now. You can't do that. You got to stay with the patient. Be prepared to administer CPR if necessary. Be prepared to give a second dose and wait for 911 to get there. You have to call 911 because that's only going to last for so long. We're only hoping to get them back before, until 911 can get there and give them the injectable. You can also I've seen people that had injectable naloxone as well, but it's not as common. There's different devices for that. There's actually a device that it's all packaged. It's almost like an EpiPen. So there's those. The most common, though, that I've seen anyways is the intranasal. So we're going to teach the patient or teach this the family about that. Nursing interventions. Anytime we're going to give Narcan, make sure that we're monitoring their heart rate, respirations, and that we're offering supportive measures and that we are protecting them. Make sure that bed's low, man, because they might start coming out of that bed. You don't want them jumping off a high bed and falling and hurting themselves. So make sure you keep that low and locked, but bed alarm on, monitored. Really, you shouldn't leave the bedside. If you've had to give somebody an naloxone, there's no reason to leave the bedside because, like I said, the potential for them to circle back around and go back down is very, very high. All right, so we're going to step away from opioids and talk about migraines. There's a lot of research out there that shows that migraines don't really respond well to opioids. You'll still, though, see them used sometimes for migraines. But there's other medicines that we use, and we're going to talk about one in particular. A migraine and a cluster headache, these are similar in a lot of ways, but there's some differences. The migraine is a unilateral throbbing head pain, usually associated with nausea, vomiting, photophobia. A lot of times they can be associated with an aura, so there's something in their vision that they see. There's some that they know it's coming on. They can kind of see that thing in their vision. Symptoms a lot of times last 4 to 24 hours, but man, they can last several days. I've unfortunately have some people in my family that suffer migraines, and I just feel so bad for them because you can tell they're just miserable for that amount of time, and it's just so sad to watch someone go through that. A cluster headache is it's usually described as a non-throbbing pain located around the eye. And you get one, and then it kind of fades for a second, and then it can come back. So you can get one or more daily, and these can last for weeks as well. These a lot of times aren't associated so much with the aura, but they still get the nausea and vomiting. And these can also begin in sleep, so they can wake up with it, which is sad to hear. But there's some meds that we can use for that. There's different treatments. When you get out into the nursing world, or if you've suffered migraines, you may know this. There's different treatments that they use. Caffeine usually is a medicine that we do use, and you can actually inject caffeine. You can give it through an IV. They'll usually use that, maybe some diphenhydramine, an anti-nausea medicine. And then steroids sometimes. A lot of docs just have their own little cocktail, so to speak, of what they use for acute migraines. But home treatment is what we're going to talk about here, and that's Sumatriptan. Sumatriptan or Zomatriptan. Triptans, they're anti-migraine medications. People usually have some pretty good luck with them. It's not like a cure-all. It's not like it always works for everybody. But a lot of people have had good luck with them. They're actually going to bind to certain serotonin receptors. And what those serotonin receptors are going to do when they activate those, that's going to cause that vasoconstriction of cranial vessels. Doesn't mean it's only cranial vessels. So if you have uncontrolled hypertension or coronary artery disease, we got to be very careful because there is going to cause some vasoconstriction, but it's primarily cranial vessels. And that relieves migraine and cluster headaches for some people. And that's our indication, migraine, cluster headache. Adverse effects. Well, we talked about what they do, so you can probably immediately understand what adverse effects we would be concerned about. And that is blood pressure changes, angina, right? Because if we're causing some vasoconstriction, we may cause a little angina, and coronary vasospasm. These can also cause some dizziness. People they have an overall feeling, they can't even sometimes explain it. They're just like, I don't know, it just kind of makes me feel weird, but it knocks out my headache, so I'm good with it. I can sleep that off. Contraindicated then, uncontrolled hypertension. Definitely wouldn't want to give it to somebody that has uncontrolled hypertension. If they have coronary artery disease or cardiac disease, it's depending on the severity there, it would be at least very cautious, if not contraindicated. Pregnancy, we wouldn't want to give it to someone that's pregnant or in liver failure. Be careful with anyone with even a risk of coronary artery disease. And elderly, they're usually at risk already for coronary artery disease. Interactions, well, think about that. It works with serotonin, so SSRIs or antidepressants. A lot of antidepressants work with serotonin. especially like SSRIs, SNRIs, MAOIs, of course, because everything does. We have a potential for serotonin syndrome. Now, I actually know people that are on triptans and an SSRI, a mild SSRI, and they do just fine. But they need to understand there's the risk there, so make sure that they're following with their doctor. Patient teaching. Well, it'd be good for us to try to help them discover what are their triggers, right? So we can do that with migraine diaries, just discussing with them, what happens a lot of times before these migraines. We want to tell them what's most important is this is not a preventative medicine. This isn't a medicine for maintenance. This is not an everyday medicine. You should not be taking this every day. If you have to take it every day, there's a problem. We got to do something else because of those potential effects. It is a medicine you only take at the onset of the migraine or the headache. So let's say movies are a trigger for you, but you really got to see the new Captain America. And I get it because it was awesome. You wouldn't take this thinking, I'm just going to take this now. That way I know I don't get a headache during Captain America. It's not how this works. You take this at the onset of the headache. So you could take it with you, and then if the flashing does start to cause a headache or the screen or whatever, then you can take the medicine and hopefully that'll get you through. But you don't take it for prevention or maintenance. It's not something you take every day. Normally they tell you to take one pill. If you don't get relief from that, you can take another after usually, I think it's 2 hours. You don't want to take more than 200 milligrams though in a 24-hour period. So these are all important things to make sure that people understand. Again, not taking it every day, and they wouldn't want to because it's expensive anyways. Only take it at the onset, not for prevention, not because okay, I really want to go to the Indy 500, but every time I go, I seem to get a migraine. I'm just going to take this. It's not necessarily. You can take that with you and then take it if you do start to get the headache, but that's not really the intention of the medicine. You need to take it when you start to get that headache, not for prevention. If it's not always successful for everybody. It's important for them to understand that migraines are a complicated phenomenon that we don't fully understand. There's multiple causes of migraines. I've seen people respond very well to hormonal treatment, and something as simple as birth control pill for females. Sometimes the migraine is actually being caused by those hormonal shifts, and so they're able to regulate that, and that helps them with a large majority of their migraines. There's other medicines out there. These medicines can be taken PO or they can be taken injectable. There's various ways to take them. Some people get a lot of nausea and vomiting, so they don't want to take a PO. There's other ways for them to take it. But that's triptans. All right, so let's talk about some anxiolytics. We talked about muscle relaxers with our skeletal muscle relaxers, and we're going to talk about, and we talked about benzodiazepines for just a short second on those. But what I told you, we would really cover those with our anti-anxiety medicines, and that's where we're getting to here. So let's talk about anxiety. So what is it? It's a feeling of tension, nervousness, apprehension. It's like fear involving an unpleasant reaction to a stimulus. That's your book is going to tell you that. The signs and symptoms: the fast heart rate, rapid breathing, so tachypnea, tachycardia, elevated blood pressure, sweating. We can have anxiety can narrow our concentration. So it can kind of narrow our focus, which is good sometimes. Sometimes a little anxiety is people thrive on it, right? Some people do well when they get a little nervous before a test or before a performance, right? You get those butterflies and you feel like you're going to throw up, and some people even just throw up. I've seen performers do that. They get so nervous they throw up before they go on. But once they get on, that nervousness actually, their performance is awesome, right? So, but it can also be devastating. So what kind of non-pharmacological treatments do we use for this? Relaxation techniques, yoga, exercise actually does help with anxiety, good diet. There's quite a few different non-pharmacological things that do work for people. Benzodiazepines, these are your acute anxiety medicines, but they're good for more than just anxiety, and we'll talk about those. Diazepam, that's your Valium. Lorazepam, that's your Ativan. Alprazolam, that's your Xanax. There's others, clonazepam, midazolam. There's a bunch of others. They usually end in PAM or LAM. I can't think of any that don't. But what these do is they potentiate GABA. And by doing so, by making that GABA more effective, that helps reduce anxiety. And for anti-anxiety reasons, we're usually giving lower doses, like 0.25 or somewhere in there. The higher doses, we use those a lot for sedation. Then also for severe agitation. So our indications, there's a bunch. Anxiety, we talked about, right? We use them for anxiety. Agitation. Muscle relaxation, absolutely. Absolutely, they're a great muscle relaxer. They are pretty much the go-to for acute muscle relaxation. The Flexeril that we talked about, or cyclobenzaprine we talked about in earlier lecture, they're good muscle relaxers, but they're not usually an acute medicine, at least not a right this second medicine. If somebody was just in like an automobile accident and they tensed up and it caused a lot of muscle pain from muscle spasms, or you break a bone, you're going to have muscle spasms. Any sort of injury like that, musculoskeletal injury, can cause that. Benzodiazepines are the go-to for those. We also use these for seizures. They're not normally used for maintenance of seizures. I'm not going to say you'll never see that, but it's not common. I'm trying to think back on any of my patients. I've had tons of seizure patients. Almost always the benzos are used for emergent situations, and that would primarily be status epilepticus. Status epilepticus is that seizure that lasts longer than 5 minutes, or reoccurring seizures, just one right after another. So they have a seizure, they come out, they come out of it a little bit, and then they bam, go right back into another one. They come out of it a little bit, bam, go right back into another one. If they keep that up, they run a risk of a lot of damage, up to and including death. So it is an emergent situation. The go-to medicine. There are other medicines we'll talk about when we get to seizures that you can use for status, but they're usually used after you give the dose of Valium or diazepam or lorazepam or whatever the benzo is that the doctor likes to use. Usually it's diazepam or lorazepam. Those are the ones I've classically used. And there's different ways to give those. So seizures. We also use these sometimes for insomnia. We talked about procedural sedation a little bit already. These are the meds that you use for procedural sedation a lot. Not always. You can use propofol. You can use other meds as well, but these are very common. Benzodiazepines are very common. Diazepam is one that they'll use sometimes for procedural sedation. Midazolam, which is Versed, very, very common to give for procedural sedation. And one of the big advantages of benzos, especially that midazolam, is when you give them at that dosage, you just forget. You just don't remember. So if you were getting that colonoscopy and you're screaming through the whole thing and they're trying to keep you sedated, so they get you to come down, obviously they don't want you to go too far because then they'll have to tube you. They don't want to do that. So I've seen it where someone's get a colonoscopy, and unfortunately, they're just not very happy with it. Or we're resetting a sock. I'm sorry, I'm a dislocated arm or hip or whatever. I've definitely participated in that where the patient just screams through the whole thing, even though you're giving them pretty good amounts of Versed or whatnot, and then you wrap them up, you get them all done, and then you lay them back and you keep them sitting up. I don't mean you lay them all the way down, but you get them comfortable. And a few minutes later, they're like, "Man, are we ever going to do this? Or are we going to fix this arm?" And you're like, "No, dude, it's done. It's already been done. You screamed the whole thing, but at least it's done." I don't usually tell them they scream through the whole thing, though. I kind of leave that to myself. But it does happen. You do sedations, and sometimes people will still have some, they'll experience some uncomfortable experience of some sort, whatever, and you'll feel bad, and you'll definitely continue to give them whatever the doc orders to make sure that we can kind of get them lowered again, but they won't remember it usually. I'm not saying everybody. There's those extreme outliers every once in a while. If someone's like, "No, I remember the whole thing." It's very rare, though. Most people don't remember it, and that's a good thing with these meds as far as that goes. So procedural sedation, and then alcohol withdrawal. As I talked about earlier, when we were talking about opioids, opioid withdrawal very rarely kills anybody. Alcohol withdrawal, on the other hand, can cause someone to go into what's called delirium tremens and can cause death. Same with benzodiazepine withdrawal. So we actually use benzodiazepines to help level them out and then we can kind of wean them off of that. It's safer. I have certainly seen docs back in the day, they would just give alcohol, just especially depending on what they're in for. But if they were in for like some sort of procedure and they were just going to stay overnight, docs like, just give them a few beers, man, they'll be fine. And then when they get out, they can go drink. And because that's what they're going to do anyways. We're not going to cure them of their alcoholism. They're only here for this procedure. The hospitals don't do that anymore. At least I haven't seen any in the last probably 8 years. Instead, they go to the CWA, which is an alcohol withdrawal scale, and then you utilize your benzodiazepines based on that scale. So again, anxiety, agitation, muscle relaxation, alcohol withdrawal, seizure disorders, insomnia, and procedural sedation. Those are the reasons that we give benzodiazepines primarily. Adverse effects, dizziness, drowsiness, all those CNS effects. Decreased respiratory depression. Amnesia. We talked about that a little bit with the procedures. That's actually a good thing for those procedures. You don't want to remember what was happening, right? You don't want to remember that colonoscopy. So that's good. God, I remember I had to have a procedure. I had this little cyst in my neck, and they had to put me under for that. Not fully, just with MAC, which is a type of sedation. And they... I certainly don't remember anything from that, and afterwards my wife thought she was going to kill me because I just kept asking her the same thing over and over again. I'd forget, like I would ask her, I don't remember what it was, but I'd ask her the question, and then like 2 minutes later ask her the same question, and did that for the rest of the day. And luckily our marriage survived somehow. These can also cause toxicity. You can certainly overdose somebody on benzodiazepines, and we do have an antidote for the benzo, but it can be just as bad because, again, we're causing immediate withdrawal with an antidote. And what we've learned about benzodiazepines and withdrawal, it can actually kill somebody. So we don't use those as much as they once did. It can cause withdrawal symptoms. So if you're on these for long term and you stop, you will definitely go into withdrawal, and that withdrawal can be deadly. It causes liver damage, especially when we take them for long periods of time. And then we can also have what's called a paradoxical effect, which we talked about with diphenhydramine, we expect sedation, but it actually causes more agitation. You will see that especially in the elderly, at least in my practice, what I've seen it. The doc, the person will be very agitated. The doc will order like a small dose of lorazepam or, whatever. And they'll actually become a little more agitated, or they'll just start literally crawling up the walls at that point. So sometimes we'll use other things, clonidine. There's other medicines that aren't benzodiazepines that the doc may go to first, especially with the elderly, because of that potential paradoxical effect. Contraindication, of course, respiratory depression, sedation. If they're already sedated, we don't want to continue to sedate them. Sleep apnea wouldn't be the best idea to give this to them. Be careful in people with a history of drug abuse or alcohol abuse. If they have active liver disease, that could potentially be a contraindication depending on what's going on. And depression. Be real careful with that as well. Interaction, of course, any CNS depressant is going to interact with CNS depressants. It's going to interact with barbiturates, opioids. Those are all CNS depressants. It can actually interact with oral contraceptives as well. It can, depending on the type of oral contraceptive, it may interact with the benzo itself and cause the benzo to be more effective or even less effective, but just know that there's a potential there. Patient teaching, or definitely teach them, don't do anything that needs your full attention, right? You can't give somebody these medicines and say, hey, safe travels. I had a patient come into my ER through an ambulance that way. The doc, he went in, had a lot of pain from an injury. The doctor gave him some Valium, gave him a Valium injection, and then let him drive home. And he didn't make it very far and ended up right in our ER. Don't ever do that. Anytime you're giving somebody a CNS depressant, usually you have to sit on them for 4 hours before you can send them home on their own, maybe even more depending on what's going on. So the bottom line is to know if you are in one of those acute care centers or even the emergency room, which emergency room is an acute care center, and most times, the majority of people that come to your ER, you're going to send them right back home or wherever it is they came from. You can't send them out on their own if they've had something that causes CNS depression. So I always made sure that they had a ride. And it's not that they said, oh yeah, I called my cousin Carly and she's going to come pick me up. Okay, fine, here's your medicine. No, Carly's got to come in. I got to see the whites of her eyes. Now, if it's obviously an extreme situation, like they broke their arm and it's, laying cockeyed from them, we're going to obviously take care of that. But if it's just we're giving them a little pain medicine to get through so they can get to the or to the pharmacy and get some pain medicine, and it's not an emergent situation, I'm going to make sure I can see the whites of their eyes, or here's your prescription, you can go to CVS and get it, and then when you get home you can take it. So just always keep that in mind. Otherwise, you're going to be sitting on them, and you may be sitting on them for 4 hours, and that's a room that could be used. Not to mention they're in your care. So if I've had situations where they made me keep them out in the waiting room, and that's they're kind of under your care. You got to be careful with that. Do not stop abruptly. We're going to teach them do not stop abruptly. Medication can cause dependence. Store safely, don't share with others. And then, of course, avoid alcohol and other CNS depressants. I talked about the antidote. The antidote's called Flumazinil. It's Flumazenil, also known as Romazicon. But again, it causes that immediate withdrawal, which can put them into seizures and worse. So it's not like we use it all the time. It's not like it used to be. They've definitely cut back. In fact, I don't believe EMTs can give it anymore, or paramedics. I don't believe they keep that on them anymore like they used to, for those reasons. But there is an antidote if needed, if the risk benefit is there. Buspirone is another anti-anxiety medicine, but it's mostly for generalized anxiety. it's not really an acute medicine. It's not to say I haven't seen a doc try to use it as an acute medicine. It's just not really intended for that. The action of it, I don't worry so much about the action because we're not 100% clear on the action. But the indication is just generalized anxiety. Adverse effects. This one can cause dizziness and a headache. This one actually can cause some people to have some agitation. Most common adverse effect, though, is just GI distress, maybe a little nausea. Contraindicated. Well, the contraindication and the interaction go hand in hand. The interaction is MAOI. There are other interactions we'll talk about, but you cannot take this concurrently with an MAOI at all. And in fact, you have to wait 2 weeks between an MAOI and buspirone use. So if you're having generalized anxiety, but then they determine, you know what, you need an MAOI for depression because this just is, we think, the best course of action, you will, they have to stop that buspirone for 14 days, and then they can start to use the MAOI. Be careful, though, in people with hepatic or renal impairment. So interactions, we talked about the MAOI, also interacts with erythromycin and St. John's wort, and can interact with grapefruit juice. So this would be one that we'd want to make sure we tell them, don't drink grapefruit juice. First off, it's just as disgusting. But second off, it's not good for you to take with buspirone. Patient teaching. Teach them that this can cause that dizziness, some drowsiness, but also may cause a little agitation in some people. GI upsets, the most common adverse effects, so take it with a meal. Let them know that this is not really an acute medicine. So if you're having an acute anxiety attack, this isn't really the best plan. It takes a little while for this to start to work. It's not like an immediate medicine. It takes a few days or so to start feeling those effects. So it's not really meant for that. Don't take, obviously, with an MAOI, so make sure the patient understands they need to tell their providers that they're on this medicine when they're getting new medicines prescribed to them. Avoid grapefruit juice, of course, and then we're worried about that St. John's wort, so that can be in herbal preparations. Of course, St. John's wort itself, but then there's other herbal preparations that people take that have some St. John's wort in there. So we'd want to make sure that they understand not to take herbal preparations without talking to their doctor. Insomnia. So now this obviously is people are having difficulty sleeping for various reasons, and we do have some medicines that we use for that. Zolpidem is very common medicine. That's the one that I've always seen in the hospital used. The most common one I've seen used in the hospital is actually diphenhydramine, which we already talked about. But Zolpidem is also common as well. It's called Ambien. There's others as well. Zalplon, which is Sonata. There's others. But for now, we'll talk about Zolpidem because it's the most common one you'll see as far as these types of insomnia agents. These also act on GABA. They potentiate that GABA, but not quite to the extent that the benzodiazepine is going to, but it's just going to help put them to sleep. And that's our indication, insomnia. Adverse effects. Well, obviously drowsiness. It can cause daytime sleepiness in those that are taking it. It can cause, some people can become dependent upon it. In fact, they'll take like 5 milligrams, be doing just fine, but they're taking it way too often, or they're relying on it too often. How about that? And then next thing they know, they need a little bit more and a little bit more. And well, you can max out on that quickly, and then it's not working for you anymore. So risk for tolerance and dependence is there. It's contraindicated with lactation or nursing mothers, and we'll be real careful really in pregnancy. It's a category C pregnancy medicine, so we'll be careful with it. Also be careful with people with renal or hepatic dysfunction. If they have respiratory dysfunction, it's going to be a risk-benefit type of thing, but the risks are pretty high, so I'd be careful with that. Interacts with other CNS depressants. Outpatient teaching. Well, first off, make sure that you've got enough time and that you've set up a good environment to sleep in, right? So a nice, dark, preferably cooler environment with, not much noise. So try to educate them on the importance of setting up a good sleep environment. Take the medicine just before bedtime. Make sure that they have 8 hours of sleep. So this isn't something that you wake up at 2 in the morning and go, oh my God, I got to get up in 5 hours and I've barely gotten an hour's sleep. I'm going to take my Ambien real quick. It's not like that. They need to make sure they got 8 hours, because if you take this and you've only got 4 hours that you're going to sleep before you have to get up, you can certainly continue to have that drowsiness and put yourself at risk, especially if you're going to manipulate heavy machinery. Do not share medicine. They usually prefer you take this on an empty stomach. Other meds that we use for anxiolytics or hypnotics or insomnia. I talked about diphenhydramine already. That's an antihistamine. Hydroxyzine is another one that we use sometimes for this. Beta blockers, propranolol. We use that usually for performance anxiety. It's more of a stage fright type of thing that we use that, because it actually, all it does is just help reduce the symptoms, right? It helps reduce that tachycardia, that sweating and the tension. And some people find that helpful. Antidepressants. This is a big one. You'll be giving antidepressants probably every day of your nursing career that you are administering meds. So there's 3 neurotransmitters associated with depression. It's your dopamine, serotonin, and norepinephrine. The theory behind the most common antidepressants is the biogenic amine theory. And what that says is there's an imbalance of some sort in these neurotransmitters. There's a decrease in these neurotransmitters in some way. So they're going to try to increase the stimulation of these neurotransmitters. That's the whole point of every antidepressant we're going to talk about in this chapter. They're called the biogenic amine theory. And those biogenic amines, again, are serotonin, norepinephrine, and dopamine. Signs and symptoms of depression: low energy level, sleep disturbances, and it can either be too much sleep or too little sleep, not able to get enough sleep. Change in appetite. Again, you could eat too much, you could eat too little. Change in libido, inability to perform activities of daily living. We've all been there where we've been a little depressed and, you just don't ever want to get out. I'm just not going to get out of this bed today. Or I'm just not going to do this thing that I need to do. It does occur. I've seen people, though, with a severe depression where they literally just will not get out of bed for months. Long time. The famous case of that is Brian Wilson of the Beach Boys. He spent years in bed, basically. The poor guy with major depression. Here's a guy that had the entire world, right? He was one of the biggest stars in the whole world, had all the money he could imagine, and he still was just clinically depressed. It can happen to anyone, and I've worked with these people before, and it's just so heartbreaking to watch someone go through that. And then, of course, just the overwhelming feeling of sadness or hopelessness. A lot of times these guys are disorganized. So those are some of the common signs and symptoms of depression. Some meds that we use. Again, these work on the biogenic amine theory. So we're trying to increase that those neurotransmitters, or at least the responsiveness of those neurotransmitters there in the nerve cleft. So with the tricyclic antidepressants, these ones were concentrating mostly on serotonin and norepinephrine. So that's how they work. They inhibit the reuptake of serotonin and norepinephrine. During lecture, we'll get into, I'll put this on the board and give you a picture of how this works, and to hopefully let you see it a little bit more clear. But again, it's just stopping that reuptake from the nerve terminal, so it stays there in the gap and keeps activating those receptors. Indication, depression, of course, because that's what we're talking about. You'll actually see these sometimes used for insomnia, and some people have used them for chronic pain. Adverse effects. Well, there's quite a few. Sedation is one. These can cause orthostatic hypotension. We get anticholinergic effects from TCAs. You can't see, can't pee, can't spit, can't poop. These are also associated potentially with cardiovascular effects like arrhythmias. They can potentially lower our seizure threshold, which will, anyone that is at risk for seizures already, that's a big deal. But they can cause seizures, but especially in those with a history of seizure. And then all of these antidepressants nowadays have a black box warning. That black box warning is the risk of suicide in people less than 25. So it's something we'd certainly need to take into consideration. It'd be contraindicated during an acute MI or people with seizure disorders. Also, they usually don't like to give these to people that are pregnant or lactating. Be careful, though, if they have a history of cardiovascular disease or arrhythmia. Anything that would be exacerbated by those anticholinergic effects, such as BPH or glaucoma, or any sort of urinary obstruction or retention. Interactions. Well, other antidepressants, CNS depressants as well. MAOIs. MAOIs can't really be taken with any other antidepressant. And then antihistamines can actually sometimes interact with these as well. It will actually increase the level of the TCA. Patient teaching. We'll teach them, hey, it may cause some sedation, so don't do anything that needs your full attention, especially when you first start these. Let's see how these are going to affect you. Takes about 2 to 4 weeks before you start noticing improvement. So it's not like they're going to go to the pharmacy, get this, take the pill, and be happy all of a sudden. It doesn't really work like that. It's not brain candy. That was a good movie. Do not stop abruptly, though. Once you start taking these, you can't just immediately stop, because then we can have some withdrawal problems. And then, of course, in anyone less than 25, we need to discuss the increased potential for suicide risk. And talk with maybe family and loved ones about signs and symptoms to watch for. The big ones, the MAOIs. These are the last resort medicines as far as antidepressants are concerned. We've tried the SSRIs, probably multiple SSRIs, TCAs, SNRIs. Nothing's working. We're still clinically depressed. Last resort medicine is going to be your MAOI, and it's because its compliance is tough. These are not easy medicines to take, and you'll understand why once we start talking about them. Phenylazine is the most common. It's called Nardil, but there are others. Carboxazid is some, but phenylazine, that's the most common one. You don't see these, though. It's not like these are common medicines. Again, these are last resort medicines. If you work in psych, you'll probably see these more often. If you don't, you may see them very rarely. The action. So here's how these work. These block MAO, okay, which is your monoamine oxidase, from breaking down those 3 biogenic amines we talked about, the norepinephrine, serotonin, and dopamine. MAO sits there in that nerve cleft and helps clean that up, right? So we release those neurotransmitters, and it stimulates, right, and it keeps the nerve stimulation going. But it needs cleaned up. Otherwise, it would just be constant activation. We do that by a couple ways. One, we reuptake and back into the nerve terminal, but we also, MAO will come in and clean that out. We'll just break them down. We'll break down those neurotransmitters, which is good for the most part. But in people with severe depression, or depression, period. There's a potential that they're not getting enough there to cause that stimulation. So we want to increase the amount of these neurotransmitters in that nerve gap. And one way to do that is to just stop MAO from breaking it down, which is good, and it does help, but there's some problems with that. So indication, depression, we also may use these for bulimia. Adverse effects. This can actually, unlike the tricyclics, these cause stimulation, CNS stimulation. They can also cause orthostatic hypotension, but here's the kicker. Orthostatic hypotension, when taken properly, very important to understand that, write that down. When taken properly on the proper diet, orthostatic hypotension is more likely. However, when not sticking to the MAOI diet, you can actually cause a hypertensive crisis, like a severe hypertensive crisis, an emergency situation hypertensive crisis. So I'm going to say it one more time. Orthostatic hypotension when taken properly on the proper diet. Hypertensive crisis when not following the MAOI diet. And the MAOI diet is decreased tyramine. You don't want to take in, or you don't want to eat foods that are high in tyramine. And we'll talk about that here in a minute, about what foods are high in tyramine and why that's important. Contraindicated, certain adrenal tumors, cardiovascular disease, renal impairment. Be careful in people with seizure disorders. We may affect that seizure threshold. These can actually interact with certain diabetic medications, so be real careful in people with diabetes. It may actually cause a decrease in blood sugar with certain diabetic medications, and that could be scary. Also, be careful in people with hypothyroidism. Interactions, we discussed this, almost everything. I won't say everything, it's definitely not everything, but a lot, a whole lot. Any other antidepressant, almost any other anti-psych medicine, there's a potential there for interaction, some more than others. Antihypertensives, we can definitely have an interaction with those. Decongestants, which we already talked about. Caffeine actually can interact with MAOIs, with that agitation. And then tyramine-rich foods. That's a major interaction. That's the one that can potentially cause that hypertensive crisis. Patient teaching. So we're going to teach them to obviously avoid foods containing tyramine, and we'll get to that in a minute. I got a slide about that. It's going to take about 2 to 4 weeks to start feeling effects. It can cause some agitation, so be careful of that. When taken properly, it may cause orthostatic hypotension. Fine. They need to understand to rise slowly, so change position slowly, and be wary of that. Be aware of that potential for dizziness. Interacts with other drugs or foods that can cause hypertensive crisis. And, of course, never take any other antidepressant medicines while on an MAOI. There's severe risks involved, especially with that Serotonin Syndrome, but just there's severe risks involved, so they should not be on these concurrently with other antidepressant medicines for the most part. So let's talk about tyramine. So tyramine is an enzyme that's found in food, and it's found in the yummiest of all foods. It's normally broken down. It's in the GI. So MAO is in, we talked about that in those nerve terminals there to help clean that out, to keep those neurotransmitters from accumulating too much there. But it's also, so that's one thing it does. It breaks down those neurotransmitters. Another very important job it does is breaks down tyramine. And we find tyramine in lots of foods, the very yummiest foods. when we block MAO, we block MAO. So we block it in both places. If we block it from breaking down tyramine, when that accumulates in the body, that can cause a hypertensive crisis. Normally it's fine. You can eat these foods and your body, your MAO breaks it down and everyone's happy because the food's tasty and you're not dying of a hypertensive crisis, right? Which is important, usually. If we're taking an MAOI, though, we're no longer breaking that tyramine down. That can cause an accumulation of tyramine and lead to that hypertensive crisis. So let's look at those foods that people need to avoid, and you can see why these can be compliance is an issue. So foods high in tyramine, aged cheeses like cheddar cheese, blue cheese. I'm already out. I'm gone. I'm walking. I can't. No. Fermented meats, yeah, I can live without I can live without the chicken pate and beef liver. Caviar, I've just never cared about. Fermented fish, come on, man. But, if you're into it, by all means, please. Brewer's yeast, which is used in a lot of yummy stuff. Fafa beans. Red wines like Chianti. So Chianti and Fafa beans, we already know Hannibal Lecter is out, right? Dude can't have an MAOI. Or maybe they should put him on an MAOI. I mean, I know it's not maybe the most ethical thing, but, it's a fictional character. Maybe not the worst idea. Anyways, smoked or pickled meats. So sausages, salamis, pepperonis, corned beef, literally the greatest things on earth. Also beers. Oh, man, come on. If I can't have sausage and beer, that's tough. Avocados, distilled liquors, chocolate, sour cream, pineapple, grapes, raisins. I mean, very good stuff. And so you can see how compliance can be tough with these. I mean, I know I would have a very tough time. If I had to do it, God forbid, I would definitely do it. It's worth it. But you can see how that can be tough. So we need to make sure we're educating them on this and the importance of avoiding these foods because of the potential there for the hypertensive crisis, which can be an emergency situation. So please look this table over and just get a general idea of these meds. If it's smoked or aged meats or cheeses, forget it. That's high in tyramine. For the most part, alcohols, anything that's fermented or cultured, such as yogurt, sour cream, cottage cheese, all these things are fermented and or cultured, and they're higher in tyramine. So that's a good way to think about it. If it's been fermented or aged, pickled, usually they need to avoid that. SSRIs, the most common antidepressant. It's kind of scary how common these are. Not because for any reason, like, if you need them, you need them. By all means, please, if you need them, take them. But sometimes practitioners get a little too reliant, where the true best practice with these medicines is that you are on the medicine and some sort of counseling with those to help you and to hopefully get you someday off the medicine. But unfortunately, the compliance with that is almost non-existent. It's rare. You go in and talk about you're having the blues. Doc will throw you on these and leave you on it and forget it. It's common. It's just common. I mean, heck, they basically have them in gumball machines in some places, right? You just walk in, put your quarter in, turn your wheel, get yourself a handful of SSRIs. It's become pretty common. And again, they're great meds for those that need them, and they do work, but they really should be combined with some sort of counseling to help and hopefully get you off them, because you don't need to depend upon them all the time if we can help in other ways. But they still do work, and they are very common, extremely common. You're going to see people on them all the time. And everybody that's on them isn't necessarily taking it from depression. As you'll see, there's multiple indications. Common ones, fluoxetine, citalopram, sertraline. Fluoxetine, that's Prozac. Citalopram, Celexa. Sertraline is Zoloft, but there's also paroxetine, which is Paxil. There's Lexapro. There's a bunch of them. Fluoxetine is the most common. Is the one that's been around the longest, the one that we're most familiar with, Prozac. But certainly you will see the others. So I've seen sertraline and citalopram all the time. And what these do, we talked about with TCAs, how they block the reuptake of norepinephrine and serotonin. These block the reuptake of serotonin, just the serotonin. Not much effect on the other two. It's just the serotonin for the most part. And so that's your action. And our indication, just like we talked about, depression for sure. I mean, that's what we're talking about here. But there's others, because these are so well tolerated. We use these for a lot of other psychosomatic disorder, not psychosomatics, other disorders, such as obsessive compulsive disorder, panic disorder. You'll see them sometimes used with post-traumatic stress disorder, sometimes in people with bulimia, or premenstrual dysphonic disorder. Adverse effects. Well, there's that black box warning, just like I talked about it's with all antidepressants, really. Suicide in people less than 25. These can also cause some CNS stimulation in some people. They can cause some weight changes, either way. Withdrawal symptoms for long-term use. So if they're on them for long-term, they don't want to just stop cold turkey. Sexual dysfunctions, potential. And then there's a potential for serotonin syndrome. Taken by themselves, it's rare. Serotonin syndrome is rare anyways, but especially on an SSRI when only taken with SSRI. However, if you're mixing them with other antidepressants or other serotonin medications, such as the Sumatriptan we talked about, then we increase the risk. There are other serotonin medicines. Ondansetron, we're going to talk about here in a few weeks with GI meds. That is a serotonin medicine. Again, we can increase our risk for serotonin syndrome when taking ondansetron with the SSRI. It doesn't mean they're going to get it. It doesn't mean they're at like extreme risk for it. It just means we need to know what to watch for. We need to know what to educate them about. So serotonin syndrome is usually marked by they'll start having some agitation. Now these SSRIs can cause a little bit of stimulation already, so maybe a little bit of an agitation, but they start becoming more agitated, more anxiety. They'll start having confusion. They'll start having hallucinations. Now we're starting to get scary. They'll get into a fever. They may get, and then of course with the fever, they'll get diaphoresis. They'll get some tremors. Serotonin syndrome is definitely a serious thing that we, need to be able to know the signs and symptoms for and to warn people about. And so we want to make sure that people understand to always tell their doctor when they're on an SSRI to understand the potential for serotonin syndrome, especially when we're taking multiple serotonin medications, such as multiple antidepressants, or taking it with those anti-migraine medicines, or the ondansetron, which again is another very common medicine. There's others. There's a lot of others. Lithium, St. John's wort, which is one of those herbal medicines. Some people use St. John's wort for depression. Fine, except when you're taking it with an SSRI, you increase your risk of serotonin syndrome. Contraindications. Your book's going to tell you bipolar disorder. It's not. The problem is you will still see people with bipolar disorder that has these, as we've learned through this course. Contraindications, it's always a risk-benefit thing. So you'll sometimes, even when it's contraindicated, the doc has decided but the benefit's going to far outweigh what risk this patient has, right? Each patient's different on their potential risks. Be careful, though, in people with, of course, renal or hepatic dysfunction. But if they have a seizure disorder, we may decrease that seizure threshold. So be careful with that. It can affect some diabetic medications. It can anyone with a history of GI bleed, we'd be careful with because there's a potential there to cause some ulceration. Interactions, MAOIs, we talked about, TCAs, triptans, St. John's wort, some anticoagulants, right? We're going to increase the risk for bleeding. NSAIDs, because we talked about that risk for GI bleeding with these. There's quite a few interactions. It doesn't mean people won't take these with those medicines. It just means we know we need to be more careful. I know someone that is on both a triptan and an SSRI and also takes ibuprofen at times for their headaches. So we just know to be careful, okay? Patient teaching. Takes about 4 to 6 weeks before you start to see improvement. Again, black box warning, increased risk of suicide in people young, less than 25, so teens, young adults, anyone less than 25. Can cause some insomnia, and then of course don't take with herbal preparations. There's another med that I don't have a slide here for, but I just want to cover real quick because they're becoming more and more common, and that's SNRIs. SNRIs block both serotonin and norepinephrine, much like a TCA. The difference being they don't have a TCA, the tricyclic antidepressants. They're going to have also a muscarinic effect. That's why you're going to get the sedation. These SNRIs don't have that, so there's less risk for those adverse effects. So SNRIs have become far more common. The most common one I've seen is duloxetine, also known as Cymbalta. I'm seeing it more and more. So it's very similar to a TCA, but doesn't have all the adverse effects associated with the TCA because we don't have those muscarinic effects. So just kind of understand that. Just a sidebar there on SNRIs. So serotonin and norepinephrine reuptake inhibitors, and that's your duloxetine. Just so you can kind of, you will see those, and I want you to be aware of those. Bupropion, that's your also known as Wellbutrin. This is a lot of times used for like seasonal depression. Nowadays, more than anything, it's used for smoking cessation. They're not fully aware of the action, but they believe it blocks reuptake of all three of the amines, but not to the extent of the other medicines. So it blocks serotonin, norepinephrine, dopamine. At least that's what they believe. It's a weak block of that reuptake. Again, indications, usually it's like seasonal depression or seasonal affective disorder, sometimes they call it. Smoking cessation seems to be the most common indication nowadays that I've seen it used for, and it seems to work pretty well. Adverse effects, GI distress is the most common. However, this will also potentially lower the seizure threshold, so anyone with a risk for seizures would be really careful with that. Can cause headaches and also appetite suppression, so you would not want to use this in anyone with bulimia or anorexia or anything like that. Contraindicated, I already said bulimia and anorexia. Seizure disorders, would be really careful with that. Lactation, be really careful on anyone who's pregnant. History of drug abuse sometimes can be abused here. Interacts with, of course, MAOIs, because any antidepressant's going to interact with that. Patient teaching. So, we'll let them know that this can decrease appetite, so be careful with that and watch for weight loss. There have been people that have abused this medicine for that exact reason, to cause the weight loss. May cause insomnia, and then of course anyone that's at risk for seizures, this can increase that risk. Psychotherapeutic medications. Let's talk about schizophrenia. All right, the characteristics of schizophrenia, those hallmark characteristics: hallucinations, delusions, paranoia. They also sometimes have speech abnormalities. It can be very debilitating. It's just so sad to watch somebody, especially if you've known them for a long time, and then when they start to get into schizophrenia, it's just heartbreaking to watch them and the family deteriorate. It's just heartbreaking. The causes aren't really known, in all honesty. There seems to be a pretty strong genetic correlation. There may be some sort of chemical abnormality involved. They're not 100% sure. They do know that there does seem to be a genetic association. Typical antipsychotics. So haloperidol and chlorpromazine, these are the more common ones you're going to see. There are certainly others. Chlorpromazine is your Thorazine, and your haloperidol is your Haldol. Haldol is very common. I've given that quite often. This blocks dopamine and depresses the RAS. So what that does is it just helps limit the stimulation that's coming in, right? So these guys are kind of suffering from some overstimulation. That's what's causing the paranoia and the hallucinations and such. This slows that down. So our indications, schizophrenia, of course, that's what we're talking about. Psychosis. We will actually give haloperidol in times of acute psychosis. You'll see that given. Sometimes for bipolar disorder and also Tourette's syndrome. Adverse effects. So both typical and atypical antipsychotics can potentially cause extrapyramidal effects, which we'll talk about here in a second, also known as EPS. But typical antipsychotics are far more associated with EPS, or extrapyramidal effects. And that's extrapyramidal. And we'll talk about those here in a second, and you'll really get into those with psych. We're going to touch on them here. I don't expect you to know everything about it. I just want you to know a little bit so you understand these medicines better. These also are associated with the classic anticholinergic effects. Can't see, can't pee, can't spit, can't poop. May cause some sedation. In fact, it's very common. And hypotension. Another potential adverse effect with these medicines is neuroleptic malignant syndrome. And neuroleptic malignant syndrome is kind of like a severe EPS reaction. It's uncontrolled movements. It's very severe. If you look up some videos on people that have it, you can see what I mean. And it can actually be deadly. So we're going to look for those extra movements and really make sure they understand to call the doctor when they have that. They could be just having an EPS. It could be going into neuroleptic malignant syndrome. Contraindications, severe depression. Think about that, because potential what they believe is causing some of that depression is a decrease in those 3 biogenic amines, one of which is dopamine. So we wouldn't want to use this to block dopamine if we have severe depression. Parkinson's disease. The whole mechanism of Parkinson's disease is decreased dopamine, right? So the substantia nigra has been damaged. We're not producing dopamine in the CNS like we're supposed to. So we start having Parkinson's disease. So the last thing we want to do is further decrease the amount of dopamine available. Dementia and severe hypotension. Be careful in people with cardiovascular disease, hepatic or renal disease, seizure disorder, prostate enlargement. Interactions. Can interact with any Parkinson's diseases, medications, especially levodopa. That's the big one, because that's your dopamine. Also, anticholinergics, because we're causing those anticholinergic effects anyways. Beta blockers and CNS depressants. Patient teaching. Take exactly as prescribed. That can be a problem. The people with schizophrenia aren't the most reliable for taking medicines anyways, especially when they take these meds and it starts making them feel better, and then they think they don't need to take them anymore. Oh, I'm better. I've gotten better. I'm over it. The meds help. Thank you, but I don't need to take them anymore. Unfortunately, that's not the case. They will relapse. Can cause dizziness or drowsiness. Avoid alcohol. Discuss over-the-counter medications, herbal medications, and then, of course, notify the provider of any extra movements. That's your EPS, and that'll make sense here in a minute when we talk about those. But if they notice lip smacking or uncontrolled tics, or even if they're just having difficulty moving, they're trying to move their arm, but it's not moving the way they want it to. They're just not able to control the movement as well. They need to let the doc know because they could be getting some EPS there. Let's talk about extrapyramidal symptoms. There's 4 primarily that we're going to talk about. Neuroleptic malignant syndrome you can count that as one, I guess, but it's more like a severe EPS. The 4 classics here. In frame A, you see that guy kind of hunched over there, or his neck is anyways, drooling. That's called dystonia. It's spasms of the tongue and neck, and it causes like that abnormal neck position there, abnormal eye movement, and then excessive salivation. B, that's kind of a representation of akathisia. That's a continuous restlessness. I mean, these guys just cannot sit still. They're constantly moving. It's not like me sitting there waiting in the doctor's office where I'm tapping my foot. If I notice I'm tapping my foot, I just stop it. These guys ain't stopping it. They're constantly tapping, and they're constantly moving their arms and legs. I mean, it can get real bad. C is Pseudo-Parkinsonism. So that guy, he's got the masked expression on his face, shuffling gait, difficulty with his ambulation, that muscle and fine tremor that you'll see. And slow movements. And the reason for that is obvious, because we're affecting dopamine. Just like with Parkinson's disease, when we have low dopamine, that's what causes Parkinson's. If we do that artificially with medicines, we're still going to potentially cause that reaction, which is the Parkinson's-like syndrome or pseudo-Parkinsonism. And that last one there is called tardive dyskinesia. So it's abnormal muscle movements, but a lot of times it's like lip smacking, tongue darting, chewing, like this. That guy there, I've taken care of a few people with this, especially when I worked in group homes. There was a time when people were treated for developmental disabilities in central hospitals like Central State and these long-term psychiatric facilities where they just loaded them up with typical antipsychotics, unfortunately. And a lot of these people suffered long-term EPS. EPS, it's common for it to become long-term if we don't get on it quick enough and and switch your medicines and find a medicine combination that works for you that doesn't cause the EPS. So if you let it go long enough, it'll stay. And I just remember taking care of these guys, and their tongue, it always looked like their tongue was just always hanging out exactly like this guy in picture D. And they were constantly smacking their lips, just constantly smacking their lips and chewing on their tongue. And that's that tardive dyskinesia. It also has that abnormal movements to the aimless arm and leg movements, kind of similar to an akathisia. And these things all kind of go hand in hand. They can be acute. You'll see acute dystonia sometimes with certain medications. It doesn't have to be antipsychotic medicines, but a lot of times it is. The good news is with the acute dystonia, we can give them some Benadryl and get them out of it, and then hopefully change their medication regimen and keep them from having it. So those are the typical EPS: your dystonia, which is A, your akathisia, which is B, your pseudo-Parkinsonism, which is C, and your tardive dyskinesia, which is D. And we just went over these. So again, dystonia, that's that spasm of the tongue, neck, back, legs. It's that abnormal positioning of the neck, abnormal eye movements. Akathisia is that continuous restlessness, inability to sit still, constant moving, foot tapping. Pseudo-Parkinsonism, that's those, it looks just like Parkinson's disease, the shuffling gait, the drooling, the muscle tremors, the masked expression. And then tardive dyskinesia, that's the abnormal muscle movements, lip smacking, tongue darting, and the aimless arm and leg movements. Atypical antipsychotics. So atypical antipsychotics can absolutely still cause EPS. It's just not as marked as with the typical. The typical antipsychotics, when you've been on them for a period of time, they're much more likely to cause EPS. The atypical antipsychotics, risperidone is probably the most common. It's also called Risperdal. But there's also olanzapine, which is Zyprexa. Clozapine, there's a lot of them, and they're all still very common as well. Risperidone by far is the one I've seen the most. The action, these also block dopamine, but they block dopamine and serotonin receptors. And these have a few more indications. Schizophrenia, but also these we can use in bipolar disorder, psychotic symptoms, psychotic disorders. Adverse effects, anticholinergics again, anticholinergic effects, can't see, pee, spit, poop, tremors, weight gain. These can actually cause elevated glucose, so we will want to make sure these guys are monitored. It doesn't mean they have to check their blood glucose all the time unless they're diabetic, but we are going to monitor lab values. And they can also cause high cholesterol. These can affect sleep, whether it make you sleep less or more, it just depends on the person. Contraindications, dementia, we don't really give these much in people with dementia. Be careful though in people with diabetes or cardiovascular disease. If they have a history of seizure disorders, we'd be careful, we may cause some problems there. Interactions, CNS depressants, and of course, levodopa again, because levodopa, we use that for Parkinson's disease. We do not want to block dopamine in people that already are having problems with dopamine. So levodopa for sure. Patient teachings, take exactly as prescribed. Don't stop taking it just because you think you're getting better. May cause that dizziness or drowsiness. Avoid alcohol. When we're worried about that sleep changes and weight gain, one way to help with that is proper diet and exercise. So we're going to teach them about proper diet and exercise. This can also interact with diphenhydramine, which is a common over-the-counter medicine. So just understand that they need to understand to watch for OTC medicines. Bipolar illness. Well, the characteristics of bipolar illness is periods of extreme overactivity or mania, followed by periods of severe depression. And they kind of oscillate between the two. The cause, again, we don't really, to be honest, we don't really completely know. We think there might be a biochemical imbalance. That imbalance then is overcompensated, and that's what causes the going between the mania and the depression. Lithium, common medicine for bipolar. We talked about antipsychotics, and the typical and atypical are sometimes used. Lithium is also very common for bipolar disorder. This inhibits the release of norepinephrine and dopamine, but we don't 100% understand why it's working. It's not something that they completely understand, but they do know it seems to work. Indication, again, bipolar disorder. All right, adverse effects. Weight gain. Hypothyroidism is associated with this. Renal toxicity and just toxicity in general, because this is a narrow therapeutic range medication. We need to watch those serum levels. and act accordingly. So it's one of those ones that we need to make sure we know what the levels are when we're giving it. Contraindications, pregnancy. It is absolutely associated with birth defects. Be careful in people with renal impairment. Can interact with diuretics, NSAIDs, antipsychotics. The thing about diuretics, okay, so lithium is a salt. And diuretics get rid of salt, right? Gets rid of sodium. If we get rid of salt, what's your body going to try to do to make up for it? It's going to try to hold on to whatever salt it can, right? So the diuretic is expelling the sodium chloride because it's working there in the chloride pump. Well, hey, lithium's a salt. Let's keep it. So it's going to increase the risk for toxicity with diuretics. We got to be very, very careful there. Patient teaching. They need to keep follow-up visits for labs. They definitely need to be followed by the doc. Normal lithium levels, your book's going to tell you 0.6 to 1.2. Some docs will have a more narrow preferred level, like a 0.4 to 0.8, fine, whatever. If you stick to 0.6 to 1.2, you're good. Anytime you get above 1.2, you're really getting into that danger zone. 1.5, you start seeing the thirst, lots of thirst, very thirsty, hand tremors, weakness. 1.5 to 2, you start seeing that mental confusion, tremors, poor coordination. When you get above 2, now we're getting like large amount. You're getting a lot of diluted urine, seizures, respiratory distress, and then above that we can go into coma and death. So lithium toxicity is definitely serious. We absolutely need to watch them, and we need to educate them on that. So to help with that, one thing they can do is making sure that they're drinking plenty of water and getting enough salt. The good news is, in America, we're pretty good about getting enough salt, but you don't want to go on a low salt diet, not without talking to your doctor, not without extreme, observation from the doc. So make sure that they understand they need to drink water, making sure that they're consuming enough salt. Take with food to avoid that GI upset. Obviously, again, make sure you're keeping those appointments for your monitor your levels, and then notify the provider if you start having those symptoms of lithium toxicity, like a fine hand tremor, increased thirst, or slurred speech. And there is that those lithium levels that I talked about earlier. So there's just a diagram there of that. Other mood stabilizers that we use, atypical antipsychotics, which we talked about, that we do use those as well. Anti-epileptic drugs. We'll talk about seizure medicines later. But we use seizure medicines sometimes not only for seizures, but for mood stabilizers. Valproic acid and carbamazepine, these are common mood stabilizing medicines. Carbamazepine is also known as Tegretol. Valproic acid is your Depakine. Don't worry so much about the action. There's different types of action. But your indication, again, at this point, it's for bipolar disorder or treatment of those manic depressive episodes. Also treatment of generalized and partial seizures. That's the primary. Adverse effects, blurred vision, dizziness, headache, sedation, nausea, vomiting. Then these can also cause Stevens-Johnson syndrome, so we're going to watch for that rash, and bone marrow suppression. Contraindication, pregnancy. Be careful in people, though, if they have bone marrow suppression already, because that could end up being a contraindication. If they have liver problems, because these can cause some liver issues, we'll be very careful. Can interact with other anti-epileptic medications. Patient teaching: take as directed, avoid pregnancy, notify provider if rash occurs, because we're worried about Steven Johnson's, and they're going to need periodic lab work because these can also have a narrow therapeutic range, or at least they can become toxic. So we'll watch for that. Narcolepsy. That is daytime sleepiness, sudden periods of loss of wakefulness. It seems to stem from a problem with the RAS system. There's this problem with stimulation in our response to that stimulation. So medicines that we use to treat it, there's a few that we're going to talk about. Some other common medicines is armodafinil, which is ARMODAFINIL, and modafinil. Attention deficit disorder. That's the inability to concentrate on one activity for longer than a couple minutes. It's like a state of hyperkinesis. Again, exact cause isn't 100% known. It's usually associated with childhood, but we're seeing it more and more in adulthood. There seems to be a genetic component. There's thoughts out there that there is a environmental component. It's possible. Medicine that we use to treat that, classically anyways, is methylphenidate, MEthylphenidate, or also known as Ritalin. And there's your methylphenidate there. Methylphenidate, actually, the way it works is it increases or stimulation in the CNS activity, which you would think would be weird because these guys are the classic thought of them is just always, overactive anyways. But actually that helps increase focus is the goal there. So indication, we use these for ADHD and narcolepsy. We talked about the armodafinil and modafinil, armodafinil and modafinil also for narcolepsy. I'm not going to go in too crazy on that right now. Adverse effects, weight loss. People will abuse this medicine for weight loss. It absolutely happens. CNS stimulation can actually cause psychosis, right? Because we're increasing that CNS stimulation, which is psychosis sometimes. So we got to watch out for that. Cardiovascular effects, also dependence and withdrawal. So they won't want to stop this immediately. Contraindications, cardiovascular disease, psychosis. They already have psychosis or extreme anxiety and agitation. Not a good idea to give them this. Be careful in people that have a history of abuse, drug abuse. Interacts with MAOIs, of course. Also can interact with OTC decongestants. Think back to the OTC decongestants, the pseudoephedrine. That's causing that CNS stimulation. We will continue to exacerbate that. And then caffeine, again, CNS stimulation. Patient teaching. This is a controlled substance, so it may show up in a drug screen. They need to make sure that they're aware of that. They sometimes do drug vacations so that we're not getting overstimulation. Take in the morning, monitor for that weight loss and appetite suppression. Takes about 1 to 3 weeks to see effects. They shouldn't just take these alone. They need to take these with counseling or with behavioral therapy. It's not something that you just throw a pill out and walk away. They also need that counseling.